Welcome. I think we are ready to start. So, thank you everybody for joining us. My name is Munya. I am the Medical Affairs Manager with Boston Scientific, and I am very happy to be here and to be joined by a stellar panel to discuss the treatment of atrial fibrillation and with left atrial appendage closure, and with a specific focus on the Champion AF study, which was presented at ACC last month, and a sub-analysis on the study that was presented at HRS only last weekend. So first, allow me to please introduce our panelists. So if we can just bring up the slide, Yusuf. So we have, first of all, Dr. Jens Erik Nielsen Kutz joining us from Denmark. Dr. Nielsen Kutz is a professor of cardiology and the head of the structural heart interventions at Aarhus University Hospital in Denmark. So thank you, Dr. Nielsen Kutz, for being with us today. Next, we have Dr. Mohammed Al-Hiji. The program director of the cardiology fellowship and the lead of the structural heart disease and valve program at the Heart Hospital, Hamad Medical Corporation in Qatar. So thank you, Dr. Hiji, for being with us. And last but not least, we have Dr. Haytham Al-Annazi, the head of cardiac electrophysiology at King Abdulaziz Cardiac Center and the program director of adult cardiology training. And again, thank you for being with us, Dr. Al-Annazi. So without further ado, I will hand it over to Dr. Nielsen Kutz to review with us the current landscape of left atrial appendage closure. So over to you. And sorry, just allow me one point, to mention to everybody, if you have any questions, please put them in the chat. We will make sure to address every question at the end of each presentation. So in between the three presentations. So don't hesitate to add them to the chat. Thank you.
So thank you very much. My task will be to cover the current left atrial appendage closure landscape. And I want to start highlighting that left atrial appendage closure has become a very safe procedure over the years. As you know, back in the Protect AF days, the periprocedural complication rate for this procedure was quite high. But you can see that over the years, the complication rates has come severely down, and especially with the introduction of the Watchman Flex device, we see in the Pinnacle Flex study and in the Surpass registry very low procedural complications rate. So this is not a dangerous procedure, left atrial appendage closure. It's like we do PCI, ablation, and PCI and other things. So it has become a very safe procedure. And also the procedural efficacy now is, as you can see, across several studies here, very high, approaching 99 to 100% procedural success rate with the Watchman Flex device. Part of the, I think, the improvement of the therapy and also the lowering of the complication rates is also that we have now much more focus on imaging for the procedure. Especially, there's a lot of centers now using cardiac CT to plan the procedure, to understand the anatomy, and that's a good way to really do a safe and efficacious procedure. We also have now very lately published this new implanter classification from the left atrial appendage closure group in Europe, where we have a systematic approach to looking at the anatomy, starting with the entrance or the ostium to the LAA, looking at the landing zone, overall anatomy, and whether there's hypercontractility or not, and the axis of the left atrial appendage. And there can be complexity factors related to the procedure. The ostium can be large, it can be low, there can be high eccentricity of the landing zone, there can be early bifurcations, The anatomy can be with an early sharp bend, etc. The axis can be pronounced anterior or posterior, and there can be this hypercontractility. And all those anatomical factors can contribute to the complexity of the procedure. And in most cases, we have simple and moderate procedures, but we can also experience challenging anatomy, and it's very nice to have this understanding of the anatomy before the procedure. The procedure itself is typically performed in general anesthesia and guided with a conventional TE probe. But if we are really to increase the number of LAA procedures in the future, I think we need to be able to come off the need for general anesthesia. And what is gaining more and more acceptance is the use of intracardiac echo. We can do the procedures now in local anesthesia. And there's also a number of centers that are now using in slide sedation just the mini TE probe instead of the conventional TE probes. Also, for follow-up after the procedure, there's increased understanding on peri-device leaks, on device-related thrombosis, and it's convenient for the patients to go for follow-up by cardiac CT instead of TE, and that is also gaining more and more acceptance. We have a better understanding on what's going on the atrial surface of the device after implantation. We can see both by CT and TE that there can be laminar layerings. Those are typically beneficial and just part of normal device healing. But where we can have real device-related thrombosis is when we see larger masses that are irregular on the surface or pedunculated masses, and then we have real DRT that we need to treat. Also, looking at the sealing or possible leaks after the procedure is relevant, and there's a novel classification out here where we actually look at the degree of intra-device thrombosis. This is the look that we want to have, full intra-device thrombosis of the device and no patency distal to the device. You can have situations where you have a lot of patency and very little thrombosis, and then that's where you have leaks. And then you can have minor degrees of lucency and majority of thrombosis. There you can micro leaks, and you can have some still permeability through the membranes. But if we see the red one here, we have to look and understand the leaks that can be localized in different positions. And in a lot of situations with the flex device and other devices, it can be due to malalignment. And this is an example of a malaligned flex device where we can have flow underneath the membrane fabric here, and this can be closed with a vascular plug. But I think in the future we have now the TruSteer from Boston Scientific, where we can really make sure to align our delivery sheet to the axis of the appendage, and I think we can bring down the number of cases where we have a malaligned device. I think we have also made simplicity to the procedure, especially also with the use of the steerable sheath and the VersaCross Connect. Then you can use the delivery sheet, the TruSteer sheet, also as the sheet when we do our transeptal puncture with the VersaCross radiofrequency wire. We can go through the septum and go directly with the spiral-shaped RF wire to the left atrium. And then we can use the same sheath as we did for the transeptal puncture also to deliver the device. So only one sheet is now required if we use this system, this all-in-one solution. We have also a good amount of new information about post-procedural medication out there, especially from the ANDES trial that randomized patients to either full dose DOAC or DAPT after device implantation. And that learned us that dual antiplatelet therapy is actually a combination where we see a huge amount of bleedings, also more bleedings than compared to full dose DOAC, and it's not very protective against device-related thrombosis. So we are learning more and more what will be the best post-procedural antithrombotic therapy. And one way to go is also to try to incorporate part of the antithrombotic protection in the device itself. This is a concept for the Flex Pro device, where we have this fluoropolymer coating. It means that albumin from the blood is bound very fast to this membrane, and that means that there's a lower binding of platelets and coagulation factors to the membrane here. There's an ongoing trial, or actually enrollment has finalized, so we're just waiting for the results, which will probably be within the next 6 months or so, with Watchman Flex Pro, the Watchman Flex Pro device, and 3 arms for post-procedural medication, aspirin, half-dose DOAC, or DAPT. So this will also guide us in the future to what is really the best therapy for the Watchman Flex after implantation. This is what we do now. We treat primarily patients with AFib that are unsuitable for all anticoagulation. Typically patients that have major bleeds from the gastrointestinal system or intracranial bleeds, but we also treat after electrical isolation of the LAA if we have severe renal failure patients, and there are other indications here, but most of the time patients are either contraindicated or unsuitable for all anticoagulation. I think this is the first trial to actually address also AF patients that can tolerate DOAC, namely the OPTION trial, looking at patients undergoing ablation. Can we do device closure together with the ablation and then come off anticoagulation after the ablation procedure? How is it compared to DOAC? So this is the OPTION trial, and the results were very encouraging, with a low ischemic stroke rate both for LAAC and for DOACs, and with a risk of bleeding reduced by 56% going for LAAC instead of oral anticoagulation after ablation. And if we look now on what we have of long-term data from the randomized trial and pool them together in this analysis, it looks quite good. We have LAAC compared to all anticoagulation in terms of stroke prevention. It's about the same. About major bleeding, we have a clear benefit of LAAC compared to all anticoagulation, and even on mortality we have a signal towards less mortality if we look long term from the randomized clinical data that we have now. I will also highlight the surgical results of layer 3. AF patients coming into cardiac surgery having LAA occlusion surgically compared to those not having it. Addition of surgical LAAC on top of all anticoagulation can reduce the stroke risk about 33% over 3 years. Very impressive results, very convincing for LAAC, and we are now trying to replicate the layer 3 trial in the layers 4 trial, where we do LAAC percutaneously with the Watchman Flex or the Flex Pro device in high-risk patients. So another large randomized clinical trial is under the way. But as you have heard, Champion AF has just been published. We're gonna dive into that today, and there's another large RCT going on with the AMULET trial, expected results probably 2028. But with no further delay, I would stop my slides here, and I will invite Dr. Al-Hiji from Qatar, interventional cardiologist, to speak in more details about the Champion AF trial. So Dr. Hiji, please go on. Okay, yeah,
To address right now before moving on to CHAMPION-AF. So
let's do
the
that.
question is, classification influence your choice of device and procedural strategy in challenging LAAC anatomies?
Yeah, that's a very good question. The ELAC classification is primarily a guide that can be used for, let's say, in principle, all type of devices. You can use this classification for most of the devices, and I think the devices that are out there, many of them can actually close several anatomies. But there are some anatomies where we prefer one device over another. For instance, if we have a very funnel-shaped appendage and a very long PV ridge, it's difficult to put a disc-based device because the disc will flip in and it will introduce some kind of trauma to the pulmonary vein ridge. But it's more like putting focus on the procedural steps itself and to foresee for also other devices what can really be the challenge, and also to create a structured workflow for understanding the anatomy of the LAA.
That's very nice. Maybe I could add on that. Do you routinely do CT scan in preparation of your cases, or not always? And how do you choose?
Yeah, we do it routinely, and I've done it actually since 2010. For me, it's very logical because we all know about the huge variability of the LAA anatomy, and I think it's very understandable to see a CT scan and to do exact device sizing. So I think it helps a lot.
Perfect. And just maybe, because we have one other question, but before I go to that second question, there's just another kind of related question to the ELAC classification. It just asks, how do we apply the ELAC classification in daily practice? I think you answered this, but I don't know if you have anything else to add on that.
Yeah, I mean, it's a way to, before you go to the table for the patient, to actually deal with, let's say you have a proximal trabeculation that can disturb or can interfere with your device. So it makes you consider all those anatomical details on beforehand and try to make a plan to cope with some of the details. So I think it's if you are using cardiac CT and the ELAC classification is not only for cardiac CT, you can actually look at the same anatomical features also with transesophageal echo. But if you think about first looking at the ostium, then the landing zone, overall anatomy, contractility, axis, then you go in a systematic way through all the factors that can pose a challenge for the procedure.
Very nice, thank you. So maybe final small question that came in from our participants. So do the long-term randomized control trial results change your confidence in LAAC as an alternative to oral anticoagulants for all-cause mortality benefit, or do you still see LAAC as primarily a bleeding avoidance strategy?
That's a very good question. I think the mortality, if you look back on the randomized clinical trials, the mortality signal was largest in the PROTECT AF trial. And remember that trial was, back in time, it was warfarin, and there was a very clear signal on hemorrhagic stroke or on intracerebral bleeding, that patients having warfarin on board, they had a higher rate of intracerebral bleeding and probably also fatal cases of intracerebral bleeding. I think this has changed with the DOACs because they are more safe regarding intracerebral bleeding than warfarin. But I mean, those drugs have not solved the issue of intracerebral bleeds. We also still see intracerebral bleeds on DOAC treatment. And I will say that if you can really have a difference in major bleeds, intracranial bleeds, doing stroke prevention with LAAC, there's also the potential of having a mortality benefit. But it's something that we of course, we'll have more data on. We have the 5-year analysis of CHAMPION coming up, the CATALYST, the layers 4, etc. But I think the major benefit for me of LAAC is the fact that we can avoid the bleeding that we see with DOAC treatment. And one more thing, that we can avoid the issues related to adherence, because the device is there all the time and it protects all the time. We don't need to stop anything like with DOACs for surgery or things like that. So it's a 24-hour solution. It's always there, and then the bleeding rate and risk is much lower than compared to being on an oral anticoagulant.
Yeah, thank you for that. Okay, great questions. I think we can now move on to you, Dr. Hegyi, with the presentation of the CHAMPION-AF study. Thank you.
Great. So let me share the screen. So we'll move from the landscape to the CHAMPION-AF study. All right.
Okay, we can see your slides. Perfect.
Very good. Can you see the slideshow right now? Perfect. All right, so I'll provide some insights on the CHAMPION-AF clinical trial. As mentioned, the trial was announced or presented at ACC this year and was simultaneously published at New England Journal of Medicine. So the purpose of the trial, the trial design was built to determine if left atrial appendage closure using Watchman FLEX is a reasonable alternative to an AFib patient who deemed suitable for long-term NOACs. We know that the guidelines, as explained in the prior presentation, can be in the guidelines, left atrial appendage closure can be considered in AFib patients who are poor candidate, long-term candidates for NOACs. And we know also that from real world data that the compliance to NOACs therapy is very low, and some reports states that the compliance is as low as 50% for various reasons. So answering this question is very important, as it will open some potential line of therapies for such patients, especially in the poor patients with poor compliance. That was the trial design. It randomized patients with non-valvular AFib who are suitable for long-term NOAC therapy. They had CHA2DS2 VAS score of more than or equal to 2 for males, or more than or equal to 3 for females, randomized 1:1 with intention to treat analysis at 3 and 5 years for primary endpoint and secondary endpoints. So it's important to note that the device arm received 3 months therapy of NOAC or DAPT therapy, but the majority received 3 months therapy of NOAC, and then they continued on single antiplatelet therapy. At 4 months, they had screening for device-related thrombosis. The majority had screening for with transesophageal echocardiogram, but around 18%, as will be shown in later slides, required CT scan, as the trial overlapped the COVID era, and that was logistically favorable pathway for DRT detection. So these are the primary endpoints at 3-year. The primary efficacy of composite cardiovascular death, stroke, and systemic embolism was assessed and was tested for non-inferiority, and the primary safety of non-procedural major and modified clinically relevant non-major bleeding was tested for superiority. It's important to note that the modified clinically relevant non-major bleeding, the bleeding events that are not considered to be major or does not qualify for the bleeding definition of major bleeding. However, it required hospitalization or increased level of care. Those are the predefined modified clinically relevant non-major bleeding. And at 5 years, that will be tested. the ischemic stroke and systemic embolism will be tested for non-inferiority again. This is the study methodology. So the expected rates of events were 12% in each group, and based on that, the authors decided to choose a non-inferiority margin, which was an absolute percentage of 4.8%, and it can reflect to a relative margin of 40% if the expected rates were 12% in each group. And that will translate into the need of 3,000 patients provided, which will provide 90% power for primary efficacy analysis with an expected attrition rate of 12.5%. These were the secondary endpoints that was also tested, predefined secondary endpoints, procedural and non-procedural major bleeding, which was assessed for non-inferiority, and also the net clinical benefit, which was also assessed for non-inferiority, which is the composite cardiovascular death, stroke, systemic embolism, and non-procedural major and modified clinically relevant non-major bleeding. That's the study flow. Around 1,500 patients were randomized in each arm. Total of 1,386 received the Watchman FLEX, and at 3 years, the analysis was performed as mentioned using the intention to treat analysis. Around 1,300 or 1,305 patients reached 3 years or end point event in the NOAC arm, and around 1,390 patients reached 3 years or an end point event in the device arm. These were the baseline characteristics. Around 70, the average age was about 72 years of age. Around 32% were female. Majority had a CHA2DS2 VAS score more than 3 or 4. About 58% were actually in the range of 3 to 4 CHA2DS2 VAS score. And as reflected by the HAS-BLED score, those patients were low-risk bleeders, as the HAS-BLED was 1.3%, 1.3 on average. Around half of patients had prior AFib ablation, as shown and highlighted in this table. It's important to note, and as discussed in the previous presentation, the procedure success is very high, approaching 99%. Majority of the patients underwent implantation using TE guidance, and the need for general anesthesia was about 84%. On discharge, the majority were discharged on 3-month therapy of NOAC, 85%, and around 12.6% were discharged on DAPT therapy. The serious adverse events were very low. There were no reported deaths. The pericardial effusion requiring intervention was present in about 8 patients, and other major bleedings happened in 5 patients. And in follow-up analysis using either CT and TEE for the patients who had follow-up analysis, the peri-device leak was very low. None had more than 5 millimeter peri-device leak, and around 1.4% had device leak of more than 3 or less than 5 millimeter leak. So non-significant leak was there in almost all patients. The device-related thrombus rate was above 4.8%, which is, when you compare it to the real-world experience, might be higher than the percentage reported in real-world experience. And the reason for that, they used around 18% of, in 18% of the patient, they used CT scan for analysis. And that, as you know, CT scan is very sensitive to detect hypoattenuation of the tissue that might not signify important or clinically relevant DRT, and might be a healing tissue formation on the device. And this is reflected by the practice of NOAC resumption, which was only apparent in only 1.8% of the patients. So clinically relevant DRT was low, as shown in the DRT and NOAC resumption arm, which was about only 1.8%. The primary efficacy endpoint of composite cardiovascular death, stroke, or systemic embolism happened or occurred in about 4.8% in the NOAC arm and 5.7% in the device arm or Watchman FLEX arm, and that was that led to non-inferiority with 0.9% difference between the two arms, which is way below the non-inferiority margin of 4.8%. So the non-inferiority was actually met in terms of primary efficacy endpoint. These are the individual primary efficacy endpoint components. There were no numeric differences in cardiovascular death between the two arms. There was about 1% numeric difference that did not reach statistical significance between the NOAC and left atrial appendage arm using Watchman FLEX, and that corresponds to an annual average difference in ischemic stroke and systemic embolism of about 0.33% per year. And it's so important to note as well in this trial that about 90% of patients in the NOAC arm were adherent to medication, so there was a very high adherence rate in this study. The primary safety endpoint of non-procedural bleeding, major and clinically relevant bleeding, was lower, and in the device arm it was 10.9% compared to 19% in the NOAC arm, with an absolute risk difference of about 8.1%. So superiority was met, preferring device over NOAC in this trial, and when it comes to major and modified clinically relevant non-major bleeding. And post hoc analysis looking at both procedural and non-procedural bleeding for major and modified clinically relevant bleeding was also lower in the device arm compared to the NOAC. And you can see there is slightly high number of bleeding in the device arm that actually was present in the first 6 months, and then you can see the separation of the or crossover between the two curves with increased separation of bleeding events in the NOAC compared to the device arm. And this is expected because in the first 6 months, as you know, that a lot of patients will be receiving NOAC therapy, especially in the first 3 months after device implantation. So now for secondary safety endpoint of major bleeding, either procedural and non-procedural, this also met non-inferiority as there was no significant difference between the two arms. When we look at the pre-specified subgroups, there is consistency and primary efficacy of the device compared to NOAC across a lot of subgroups, right, without a clear trend in subgroup analysis. The same thing, the device was superior in terms of primary safety across all the subgroup analysis as shown in this figure. These were some of the limitations of the trials. The trial results may not be applicable for other commercially available left atrial appendage closure devices. And the post-implant medication and for other post-implant medication regimens. As mentioned, this trial, in majority of the patients, they received NOAC therapy for 3 months. The findings may not be generalizable to all AFib patients as well, as some patients, such as advanced heart failure patients or patients who had recent MI and very recent stroke or TI within 30 days were excluded, and low EF as well were excluded. Another limitation of the trial was the non-inferiority margins that was chosen for primary efficacy endpoints was dependent on absolute number rather than relative number, and the lower than expected observed events rates in this trial in both arms might have facilitated achieving statistical non-inferiority if we use absolute number compared to relative number. So in conclusion, in patients with non-valvular AFib deemed suitable for anticoagulation, left atrial appendage closure using Watchman FLEX at 3 years was non-inferior to NOACs for the composite primary endpoint of cardiovascular death, stroke, and systemic embolism, and it significantly reduced clinically relevant non-procedural bleeding. And we will be waiting to assess the third primary endpoint of all thromboembolic events that will be reported at 5 years. So in summary, I think the Watchman FLEX trial builds on the evidence that we have from OPTION trial, which mainly was focused on ablation patients, that Watchman FLEX is safe and non-inferior to NOAC therapy when it comes to bleeding events and when it comes to thromboembolic events as well. And that will build the foundation to potentially consider Watchman FLEX as an alternative therapy to NOAC, especially in patients who have a very low adherence to NOAC therapy, and potentially we can use it in shared decision making for such patient population. Thank you.
Great presentation, Dr. Hajji. Thank you very much for a very nice review of the results of the CHAMPION-AF study. We got a couple of questions, which I'm going to read to you, and also we open it up to the rest of the faculty as well to give us your thoughts on these questions. So the first one is, do you think the inclusion criteria, so CHA2DS2-VASc score of 2 or more for men, 3 or more for women, reflect real-world patients, or is this still a somewhat selected patient population?
I think a lot of trials are ongoing right now. I think it's that the CHAMPION-AF trial wanted to answer one main question: can we use Watchman FLEX or specifically in patients who can be or can take a long-term anticoagulation without considerable risk for bleeding, okay? And usually those population, when you have a low CHA2DS2-VASc score, you will also have a low HAS-BLIT score, okay? And I think the trial itself would help in formulating or answering this question. So does that reflect, the current patient population or real-world experience? I would say yes, because we have a lot of patients who are receiving NOACs, or we think that they are receiving NOACs, but they are not a little bit adherent to the medication. So, so yes, I think it's reflect real-world experience, but does not also, however, it's not going to answer questions, for example, like patients who had elevated CHA2DS2-VASc score of more than 5 or 6. I don't think CHAMPION-AF trial answered that question, because only few patients were actually involved in the Champion AFib trial who had really elevated CHA2DS2-VAS score in the range of 5 to 6, and potentially might have, slightly higher procedure risk. But as shown in the first presentation, overall the risk of procedure is low.
I would say that Champion AF is definitely a broad AF population, but one thing that stands a little bit out is that we have a high proportion of patients that were treated by ablation, that is up to around 45%. So not in all countries we see that amount of ablation procedures being performed, but on the other hand, I think it's that will be the future. I mean, now we have the PFA technology, and also the safety and easiness of doing ablations has become much better over the years, and more and more patients are offered ablation. So in that light, I think it's also actually quite nice that we have an amount of ablated patients within the Champion AF trial. But of course, again, not in all countries we will have this proportion of ablated. But the topic of today is also to discuss this ablation versus no ablation patients.
Thank you. We do have another very interesting question. Does the net clinical benefit observed in the study could shift practice towards LAAC in lower bleeding risk patients as well?
I think Champion AFib helps in determining or giving more choices to patients, but it should not take NOAC away as a primary therapy. It's a potential alternative. I think the net clinical benefits that were tested here were major embolic events, stroke, cardiovascular death, and also combined it with clinically relevant bleeding. So clinically relevant bleeding were actually included. So I think the difference that we are seeing in net clinical benefits was mainly derived by clinically relevant bleeding. So we should be careful interpreting the net clinical benefit in the trial. Still, there is a role for NOAC. I think the trial answers a very good question, which is, can appendage closure using Watchman FLEX be alternative to NOAC therapy, especially in patients who had the real patients that probably I would offer Watchman FLEX to are the patients who I think they are not going to be adherent to NOAC. Okay, I think that's what the trial is showing to us, that potentially those patients would be safe with Watchman FLEX, given the data that we have at 3 years.
I will say that I was also amazed in the Champion AF trial. This is a low bleeding risk population having Hasbled score of 1.3. I was amazed to see a bleeding rate of 19% over 3 years. So that's actually, in a low risk bleeding population, for me, a very high rate of bleeding. And it's not just trivial bleeding, because it's major bleeding and also clinical relevant bleeding, meaning that patients are actually coming to hospital or seeking healthcare for their bleeds. And we know that one of the most important drivers for non-adherence is bleeding episodes. So if patients run into a bleeding episode, they tend to stop taking their oral anticoagulant. And so even I think we have a tendency to overlook the issue of bleeding with patients being on oral anticoagulation. And I think it's also for many, many patients a question about life quality, because a lot of patients have anxiety for bleeds, especially if they experience in daily life trivial skin bleeds, epistaxis. And what about if they are sports active and go on a mountain bike or go on a racing bike, or they do heavy work and things like that? So I think it's a it's a big issue for many patients. And of course, for those patients, it's very nice to have an alternative now, offering them left atrial appendage closure.
Absolutely, and I think this ties it well also to the final question that came also here. So in your current practice today, which patients are the best candidates for LAC versus NOAC? I mean, I don't know if it means right after Champion or before Champion, but I think getting your perspective here would be nice.
I think, as mentioned, I think the trial will expand the use for Watchman Flex and will help ensure decision making with the patients. So we have now alternative therapies. So we can show them the data, and we can explain the data to our patients. Who are the best? Potentially the best are the ones who, for some reason, would not be compliant to NOAC or had some bleeding events that will make them shy away from NOAC therapy. Those are patients that potentially can be offered Watchman Flex. We have a very good data from the option trial that potentially the combined use with ablation with Watchman Flex is, as the professor mentioned, is a good approach for such patient population as well. Yeah, I think those are the patient population.
Yeah, and I will add that until now we have, reserved this therapy for very high-risk bleeders. Often we see patients with a very malignant bleeding history, repetitive bleeds, and very often we have very old patients and also fragile patients. And we have patients with a lot of comorbidities, and there's also, in the other end of the spectrum, a limitation where we should not treat. And I believe that the Champion AF trial results will help to, let's say, use the device a little bit before in the course of the AF disease progression. Because if we come too late and have too much comorbidity, generally very high cardiovascular risk, I mean, then the benefit of this procedure is probably more limited. So my hope will be that we can offer this at an earlier stage of AF in the future.
Thank you very much. Maybe also, I don't know, Dr. El-Hanezi, if you have any insights also on that final question of who are the best, who are the candidates and the patients for LAC versus NOAC?
I totally agree with everyone that NOAC still has a role in prevention of stroke and atrial fibrillation. The device doesn't take NOAC out of the picture, but the device closures is a good option for patients with high risk of bleeding, or as what we are using now, like high risk of bleeding, or the patient is not willing to take the NOAC or not compliant with it. But for the low risk who are okay with the NOAC, who are still willing to take it, I think it's an alternative option, but I think it's not wrong to go with NOAC at this point.
Great. Thank you. Any final comments on Champion AF before we move on to the sub-analysis from our faculty? Okay. So over to you, Dr. El-Hanezi, for the sub-analysis on prior ablation versus no prior ablation from the Champion AF study. You can share your screen.
Okay. So if you mind, Sonia, just to help me with moving the slides, as I have no control. So you can go to the next one. So background, as we know now, we have the era of pulse therapy for atrial fibrillation ablation, which is becoming very common, and it is a very safe procedure, very effective, decreasing the burden of AFib in patients with paroxysmal AFib mainly. Also, we have the left atrial appendage closure, the Watchman, the Flex Watchman, which is, again, as mentioned before, it's a very safe, it's easy to implant, and has a very low complication rate. So this study just to show that if the Watchman device or WatchFlex device is still non-inferior to the NOAC in the era of the AFib ablation for patient who had AFib ablation in the past and patient who did not have AFib ablation. So also they wanted to study if the AFib ablation will decrease the risk of stroke with or without the NOAC versus left atrial appendage closure. So the purpose is just to see if it's an alternative to NOAC, mainly apixaban, in which the patient with prior AFib ablation who is indicated for long-term anticoagulation. Next slide, please. So, as been described before by Dr. Hajji, the Champion AFib trial, they randomized 3,000 patients 1-to-1 to either device left appendage closure device Watchman Flex or the regular NOAC. Patients who had the Watchman Flex device, they are on NOAC for 3 months as per protocol, and they study those patients at 3 years, and they will study it for 5 years later on. So just to go to our what we have here, that the patient had a SHAD score of 2 or more, and they all had lower risk of bleeding compared to the other patient, as we will see in the next slide. So next slide, please. So as been covered before, they look at 3-year endpoint, the primary endpoint, and the secondary endpoint. The primary, it includes the efficiency, which has cardiovascular death, stroke, and systemic embolism combined. The safety endpoint had the procedural and non-procedural bleeding. The secondary endpoint, they have, again, the safety, which is the procedural and non-procedural major bleeding, and the net clinical benefit of total outcome, which is the cardiovascular death, stroke, systemic embolism, and the bleeding. So next slide. So I will not go into details about the Champion AFib design and study, but we'll concentrate on the subgroup analysis of that study, which is the prior AFib ablation and sub-analysis. So the 3,000 patient, almost half of them had AFib ablation before at certain point. It's not mentioned exactly what point they had the AFib ablation at, and half of them had no AFib ablation or no prior AFib ablation. So as you can tell, the percentage of patients who already have the AFib ablation, it's significant. Like half of the patients who are randomized had AFib ablation, which is a very big number. So for patients who had the AFib ablation, they are again randomized for NOAC versus left atrial appendage closure device, equal numbers, and the same thing with the no prior ablation. Can you go to the next slide, please? Okay, so the baseline characteristic, they're almost equal in the main categories. Age, they're equal. The HAS-BLED score, both they have a low high split score. The SHAD score, again, they are both having indication for anticoagulation with 3.4 to 3.5 SHAD score. Congestive heart failure and paroxysmal AFib, they have almost close number. There might be more persistent AFib in the prior ablation group compared to patients who never had ablation. So major bleeding, they're both a history of major bleeding. Again, the patient who didn't have AFib has a slightly higher major bleeding, but it's not significant. So now let's go to the primary endpoint, efficiency endpoint. Next slide, please. So the primary efficiency endpoint, which is a combination of the cardiovascular death, stroke, and systemic embolism in patient who had the prior AFib ablation compared to patient who did not have the ablation, comparing both the NOAC versus the WatchFlex therapy. So there's no significant difference between the groups. If you take the primary endpoints group, they're both equal, and this did not change by doing the ablation versus not doing the ablation. So both patient group had the same risk compared to the ablation therapy. So regardless if you did the ablation or did not, this does not change the primary endpoint, which makes sense because the primary endpoint include major things like the cardiovascular death, stroke, and systemic embolism. Can you go to the next one? So the primary endpoints, again, they're equal regarding the cardiovascular death, which is already low. The ischemic stroke and systemic stroke, they have trend toward less if they have prior ablation compared to patients who did not in the two groups, but this is not significant. The hemorrhagic stroke are almost low or almost nil in all the groups. Can you go to the next slide, please? So the safety endpoint, the non-procedural bleeding. So as we know from the CHAMPION AFib, patient who had the left atrial appendage closure device has a lower non-procedural bleeding compared to the patient who are on NOAC. So comparing the two groups of either ablation versus no ablation, again, this is maintained that patient with left atrial appendage closure device still have lower risk of non-procedural bleeding, regardless if they had the ablation or they did not have the ablation, but they tend to have lower bleeding if they had the ablation. So there's no significant difference between ablation versus no ablation. Next slide. Next slide, please. So the primary safety endpoint for non-procedural bleeding, this is just to show that the non-procedural bleeding is the one that has the difference between the two groups, and patient with the major bleeding is almost equal between the two groups, but the one that has the advantage for the left atrial appendage closure is the non-major bleeding, which can be clinically significant, like the patient will be hospitalized, coming to the hospital with the bleeding. So it's still a significant outcome that we should look at. And having the ablation versus having no ablation did not change that outcome in those patient groups. Next. So the secondary endpoint, as we said, the major bleeding, there's no significant difference between the two groups, either patient who had the ablation versus patient who did not have the ablation. This did not change the outcome in the CHAMPION AFib with the sub-analysis. Both groups has no difference in the major bleeding. Can you go to the next one, please? So when you take the secondary net clinical benefit, which include everything, death, stroke, systemic embolism, and the non-procedural bleeding, there were significant difference in the left atrial appendage closure device to NOAC in the ablation group and in the non-ablation group. So both have significant difference. This is mainly driven by the clinically relevant non-major bleeding, as we saw. So the main thing that driven the secondary clinical benefit is the non-major bleeding. So having the ablation or not having the ablation did not show that, or did not remove the benefit of the left atrial appendage closure compared to the NOAC. So we still maintain a difference in the two groups. Can you go to the next one? Next slide, please. So the limitation of the study. So it's a sub-analysis of the CHAMPION AFib. It's not power enough to looking at this question exactly. The patient who had the AFib, they were not specified when did they have the AFib ablation. Did they have it on the time of the procedure, before the procedure, long time before the procedure, and that might change the outcome. Also, they did not mention what kind of ablation did the patient have and what's the outcome of the ablation. Did they have all the pulmonary vein isolated or not? So we don't have enough details of the AFib at the AFib ablation procedure. So next slide. So just to conclude, patient who had ablation or patient who did not have the ablation, they still have the same outcome regarding NOAC versus the left atrial appendage closure, which is a significant lower non-major bleeding in the device therapy. So having the ablation did not change this non-inferiority of the left atrial appendage compared to the NOAC. The non-procedure bleeding was lower in patient with the device therapy, regardless of the ablation status. So the best patient who had the best outcome, even that it's not significantly significant, it's that patient who had the device therapy and had the ablation. By numbers, they have the lowest risk of event rate, but it still did not make it to be significant. That's it. Thank you very much.
I don't know if one of our faculty here want to share a little bit some insights on this data, and then I think we have one question in the chat. So either we start with the question or your insights, whatever you prefer. Okay, let me do the question first, and then I'd love to get your thoughts on the sub-analysis. So combining ablation and LAAC could become, do you think it could become a standard strategy? And I know it's probably not directly related to champion AEF, but we're starting to see something with the sub-analysis, and also we've seen some good results with the option study. So what is your thoughts on combining ablation and LAAC and it becoming a standard strategy? To you, Dr. Hamid, first.
So that's kind of controversial, but I still keep the left atrial appendicular device for patients who are higher risk of bleeding, high Hasbled score, and or patients who are not compliant, or I sometimes keep it for patients who are asking for it. So if the patient is asking not to have the anticoagulation after the ablation, and they still have significant CHA2DS2-VASc score, it's an option to discuss with the patient. So I don't offer it to everyone, obviously. I offer it for patients who will benefit from the device closure compared to patient who, for example, patient who has high Hasbled score, patient who are not willing to take the medication. So those are the patients that we do this with, but again, it's not for everyone. It's for selected patients.
Yeah, for me, the sub-analysis here of the champion AF into ablation versus no ablation is, I think, a confirmation actually of the option trial data. I think it's nice to see that stroke rates is the same in the two groups, and that we still have this significant benefit of LAAC in terms of bleeding for this ablated population. And I agree, combined ablation and device implantation is not for all patients, especially the low-risk patients. I mean, we also have two recent trials out there, the OCEAN trial and the ablation, the AF alone trial, that indicates that if you have a low CHA2DS2-VASc score and undergoes ablation and have a good result within 1 year, you can probably be for some years without anticoagulation and still having a very low stroke rate. So I think if we discuss eligible patient for combination therapy, they should have a certain amount of stroke risk, like in the option CHA2DS2-VASc 2 to 3. And then I think it's worthwhile to consider combination therapy. And I mean, there's a lot of logic to it because you are into the left atrium you have done your transeptal puncture, and it's a matter of maybe 10-15 minutes, then you can do the device implantation with a very, very low risk. Coming later in life, you have a new situation where you add procedural risk. So I think it will, in some way, it will be the future. I mean, and also realizing that a lot of patients that actually comes for ablation, they really want to come off anticoagulation. And we all know patients that are referred to ablation and their primary desire is really, they believe they can come off anticoagulation after the ablation procedure. So I think it will be a future very logical strategy to combine ablation and device therapy. One more thing I think I find a little bit interesting with the sub-analysis here, because if you look at it numerically, there are more strokes in the group that had no ablation compared to those that had the ablation, despite the fact that at the time of the enrollment into the trial, there were 30% in both groups, ablation versus non-ablation, that had persistence or permanent AF. But I mean, if you look back, it's probably related to the fact that they had a lower total AF burden in the ablated population. And that's also a signal that, I mean, confirm that doing ablation, having patients more and more of the time in sinus rhythm is part of a good stroke prevention strategy. So getting patients into sinus rhythm and at the same time implanting their device, so when they get the recurrence of their AF, I mean, they are already protected. I think that will be a good philosophy. There's also, of course, economical considerations here in play. And we just have also to realize that LAAC is also still in development. In the future, we will have even better devices. It will be even easier to put the devices in. They will be even more safe. So I think it will be the future, a very logical structure or strategy for the future to combine the two.
I think that's a very nice view. And again, we'll get hopefully more data. We have more studies coming, and we'll understand better the combination of LAAC and ablation. I do have 2 more questions unless you have any comment, Dr. Haji.
No, I think it's well said. I think it's potentially the future is to combine ablation with Watchman, as mentioned, since you are there, and a lot of I think you mentioned that, or the professor mentioned that a lot of patients, they undergo ablation because they want to be off medication, including NOAC. So it makes sense.
Thank you. So one of the questions was, so did prior ablation not significantly change the effectiveness outcomes? So here, I think if we're talking about the primary outcome, we kind of answered it that it does not, we don't see really a difference. But one point to raise is that if we look at stroke only, the lowest rate of stroke were in patients who had a prior ablation and an LAAC. And then our final question is, so LAAC earlier in patients planned for ablation rather than waiting for bleeding issue is better. So is it better to have an early LAAC procedure done early on, or wait for the patient to have a bleeding event to consider LAAC? So again, turning maybe to you first, Dr. Anesi, on your clinical practice, and then Dr. Haji and Dr. Nielsen-Kotsk.
Yeah, so like ablation is a very good strategy for patients who have AFib. It showed that the less burden of AFib they will have in the future, that means they will have a less risk of stroke. So this is shown in that study also, even that's not significant, but it's shown in other study that patients who had already ablation, they will have a better or lower burden of AFib in the future, which decrease their risk of stroke. So even certain patients with low risk, with low Shad-Bass score, that they might even think about stopping the anticoagulation after ablation, as it will decrease the burden if there is no AFib recurrence. So as all of you mentioned, that since we are in the left atrium, transeptal is done, everything is there. So I will have lower threshold to implant the device closure therapy compared to patients who I'm bringing from home just to do the left atrial appendage closure device. So I agree, it's the future. We need better study just to show that that should be combined in all the patient. For now, it's an alternative, non-inferior alternative for certain patients, especially if you are going to the left atrium. But maybe in the future, this will be the future. I totally agree.
Thank you. Any comments from you, Dr. Easton-Kotsk or Haji? For patients planned for ablation, would you do LAC earlier or wait for a bleeding event?
I mean, the discussion here is also a matter of resources, because we cannot from tomorrow start to do implants in all patients that are undergoing ablation. So we, of course, and I agree that there will be a subset of patients that can do very well for probably a long period without the need of specific stroke prevention, simply because they are effectively in sinus rhythm. But I mean, I think we should look at each patient and also definitely take the opinion of the patient into consideration, because there can be a lot of other factors, like it can be a patient with, let's say, comorbidities like inflammatory bowel disease or other comorbidities where you can foresee there can be a likely bleeding risk for them going on all anticoagulation. There can be lifestyle matters. I think we should open the therapeutic options really to include patients in the decisions and listen to what is really what do patients really wish and what are their prior experiences being on DOACs. For sure, if you get a bleeding on DOAC, that is the strongest risk factor for a later recurrent bleeding. So what we see now is often that maybe the patient is changed to another DOAC, or even worse, that they are reduced in DOAC dose, etc. I mean, having a bleeding episode on a DOAC, that's for me really the trigger for offering such a patient LAAC. But I don't think we, of course, actively should wait for bleeding, but I would say it in that way, that patients that comes for ablation and tells you that, okay, I was in DOAC for the last 3 years, and okay, I had 2 episodes of gastrointestinal bleeding and I'm worried about that. I mean, then there will be a selection of patients that are extremely logical to offer combined procedures. But I really favor also to prioritize to inform the patients that we now have 2 options for stroke prevention. We have the DOACs taking a pill, but we also have device implantation as an option. I think that we need to, with the results from those trials here, the Champion AF trial, I think we need to really include patients in some of the decision makings here.
Thank you for your insights. Any final comments? I don't think we have any other questions in the chat, and I know we are over an hour already, but I think this was a very nice discussion, and I want to open it up for maybe just final comments from you physicians, and then we can close it. No more questions in the chat.
Well, I think just to summarize, the Champion AFib trial gave us like a platform of evidence that was lacking before to help us and help our patients making decisions in the future, shared decision as mentioned, to look at those patients who have issues with NOAC, and I think now we can, and hopefully the 5-year data can support that further. We have some evidence that left atrial appendage closure with Watchman FLEX can be a good alternative to NOAC in such patients. Whether to prefer NOAC over Watchman FLEX, I think they should be alternatives therapies, and I think we still need to wait for the 5-year data in terms of the safety or efficacy that the systemic embolic rates and strokes are non-inferior in the device arm to the drug therapy arm for such patient population.
Just a very short comment on adherence, because this trial was conducted with a very, very high adherence rate to DOACs. It was 87% throughout the trial of 3 years, and that is much higher than in real life. As you also mentioned, there is probably an adherence rate down to about 50 to 60%. So I think in real life, due to non-adherence, you would probably expect more strokes seen with DOAC treatment. But I agree, it would be very reassuring to see the signal on strokes also at 5 years. So, but this is a big step forward. We have waited so long time for, a large randomized clinical trial. I think it was well conducted, and it fulfilled all the hypothesis and endpoints. So I think we should be, this is a big milestone in the road for device therapy to prevent strokes in atrial fibrillation.
Absolutely. Thank you. Thank you to our participants for joining. Thank you to our stellar panel for being part of this important webinar. And we look forward to the next one. Have a good rest of your day and evening in the Middle East. Bye. Thank you.
Thank you so much.